Thank you for joining us on this Arthrex bunionectomy series. I'm Jim McWilliam, and in a previous episode, we discussed best practices for using the bunionectomy guide to place your guide wires. Here we'll be discussing the details of the beveled FT screws and what makes them the optimal design to secure your MIS bunion correction. Today I have the distinct pleasure of talking to Dr. Joseph Park from Los Angeles, Dr. Noman Siddiqui from Baltimore, Maryland, and Dr. Tom Harris, also from Los Angeles. Gentlemen, thanks for joining us. Dr. Park, what are you looking for in ideal screw placement?
Well, first of all, I'm looking for 2 points of fixation, so 2 screws that are parallel to each other. The first screw is more proximal through the first metatarsal base and into the capital fragment. And that's the primary fixation for reduction and fixation. The second screw, the more distal screw, is for rotational forces to minimize that.
So you want that first proximal screw to engage the cortex both medially at your insertion point and laterally proximal to the osteotomy?
Correct. And then eventually ending up in the lateral cortex of the capital fragment.
In the lateral cortex of the capital fragment. Dr. Siddiqui, do you have anything to add to that?
No, it's very similar. I just make sure I go as proximal as I can, as Dr. Park recommended, and try not to be, as I was maybe when I first started this technique, being more distal, just really because of the way the screws are made. I think they function best the longer they are and further away from the osteotomy site.
So you get more purchase in the proximal metatarsal, giving you a stronger construct.
Absolutely.
Tom, Joe suggested that he wants parallel screws. Now, we all look at parallel screws and they look really nice on an x-ray, but with these non-compressive screws, is it critical that they be perfectly parallel?
They don't necessarily have to be perfectly parallel. They could be up on the lateral where they're a little dorsal or plantar, but they don't have to be perfectly parallel.
Yeah, I think the point is we don't want to sacrifice a good result for a perfect x-ray, because a perfect x-ray doesn't necessarily equate with better function or faster recovery.
Exactly.
Dr. Siddiqui, with regards to the depth of insertion of your screw in the capital fragment, do you have any suggestions?
Yeah, I think it's important to get it as much of the screw into the capital fragment, so that's 2 parts. Making sure you're not making your osteotomy too distal, because then you're only going to have a small capital fragment to put the screws in. And then second, when you put it in, trying to not go so far that you're potentially even irritating the subchondral area, because just in case of anything that may happen. So it's like trying to find the fine balance where you're doing what Dr. Park recommended, being on that lateral cortex perhaps to be on the safe side, but being enough in the capital fragment so you have enough purchase. And then finally, that is also controlled by where you make the osteotomy. So taking a good x-ray becomes very important, because if you're angled a little bit, what may look like a good osteotomy, if you shoot down the osteotomy, may be too far distal.
I think another important thing is the x-ray projection, like you talked about. The metatarsal head is round, and the screw may look like it's captured it completely within the metatarsal head on one view, but if you slightly oblique the x-ray, you can see it's actually pointing out plantar medially or plantar laterally, which would be a bad outcome, I think. Tom, Dr. Park suggested that he wants lateral cortical purchase in the capital fragment. Do you think it's bad to go through the lateral cortex and get another level of cortical fixation into the metatarsal head?
I don't think it's bad. I think it's a hard shot. And sometimes I'll just by the angulation of where that screw is going to go, it would be coming close to the articular surface, so I won't want to do that. But if you have the right angle and you can get that fourth cortes, go for it.
I think it might even enhance your stability, right?
Yeah.
So in some cases, Joe, we have a situation where there's a very large deformity, there's a very large IM angle, and we have a very large shift. So we may have medial and lateral cortical fixation in both screws. What do you think about that?
I think for that distal screw, it's not as important to grab, and again, it's for rotation, correct? So the proximal screw, I think, is important for that cortical purchase, but not for the distal screw.
So once we've got our guide wires in place, we've ensured that our screw trajectory is going to be appropriate. And are most of you using the trajectory guide to place your guide wires for the screws?
Yes, I like to use the trajectory guide to place the guide pins first. And if I can't get both of the guide pins in the correct position, then I'll utilize the parallel guide.
Dr. Harris, prior to using our depth gauge, we want to measure the length of the screw, correct? There's a an apple slicer device. Can you explain that makes the incisions a little bit easier?
Sure. So it's basically a cannulated scalpel is essentially what it is. And you can put on a beaver blade, a 15 blade or 11 blade, attach it to it. So it just makes a really precise cut about the width that you'd need for your screw. So you don't have a ragged edge or jagged edges that are just hard to approximate, and at the end of it, even though it's a small incision, it kind of doesn't look great. And part of this, no matter what you say, there is a cosmesis aspect of these bunions. So I think that makes the incision a little cleaner, and it's essentially just a cannulated scalpel.
Yeah, so I think it helps with incision placement. It helps prevent tearing of the skin with the drill or with the screws. And I think it does. 2 weeks after surgery, you find that these incisions are much cleaner and much better healed. Patients are much happier. So once we have our incisions, we insert the depth gauge and we measure. The length of the screw is pretty true because the depth gauge is minimally invasive and beveled. But despite that, do you make any changes to the measurement of the screw? Do you select a shorter or a longer screw based upon where you've put the screw?
I find that the depth gauge is pretty accurate, but in order to bury the screw, you can subtract a couple of millimeters if you like. I like to also put that screw on top of the skin and take an x-ray too to kind of get an idea of the length to confirm that as well.
Noman, we have these beveled screws, which theoretically aren't going to be proud at all. Do you find that the length of the screw is true to the measurement, or do you find that you have to subtract a little bit too?
Yeah, I think they're pretty accurate, and I think subtracting is helpful for that reason because when the cortex is engaged proximally, I think there is a little bit of potential for, if you measure it truly to the end of the screw end, that you may be over lengthening them and pushing the capital fragment distally. So I make sure I drill far enough and then I take a couple off just so I'm not too close for those reasons described in the joint.
There's a couple reasons. One is you want to drill the full length and you want to make sure that because these are non-compressive screws, when you place the screw, you've actually drilled the whole length and you're not putting 2 or 3 millimeters more into the length to distract at your osteotomy.
Correct.
And then the other, this is a round bone that we're looking at in a flat radiograph. So even though it may look perfect on the AP, you may get an oblique. You may never even see where there's a little bit of prominence in the screw. Nothing ruins a good surgery like than having to come back 6 months later and take the screw out because it's absolutely not necessary. So I tend to countersink just a little bit. Tom, do you think it's a problem with countersinking these screws?
No, I don't think it's a problem at all. I'll go back to what I used to use were the headless compression screws, and I would take 6 off of those. And so you got to be careful not to translate that to the newer beveled screws. If anything, I'll take 2 off. And if you end up having to countersink them a little bit, I think it's totally fine. I think holding the screw up over the skin's a good tip too, but you just got to be a little careful if that's angled more plantarly or dorsally, you can get a little bit fooled and it seems a little bit longer than it should be.
And you can get a little bit of magnification too
Exactly.
if you hold it too far up off the foot. Now, once we've got our guide wire placement, we've selected the length of screw. What do you do to maintain guide wire placement while you're drilling?
So after I've measured and drilled, I'll advance them distally and plantarly as well and clamp them down with a hemostat. Well, actually, prior to drilling, I'll do that so that I don't lose the guide pin, whether it's with drilling or with insertion of the screw. So actually,
drive it distally. It may go through the joint and comes out the plantar aspect of the foot?
Correct.
Do you do something similar, Noman?
Yeah, I do exactly the same, and it also is my second visual check to make sure I'm in the right spot, because generally that should come out at about plantar to the second metatarsal phalangeal joint or midline at the first metatarsal phalangeal joint between the inner space. And then that's your check. If it's coming out there, you know you did a good job because of the rotational issues that you pointed out.
So you don't think there's an issue with driving that K-wire through the articular cartilage? You just hate joints?
I mean, I think there's some theoretical issues on the cartilage, but I think the footprint is so small that area that's being loaded is not primarily loaded during gait. So I think it's minimal.
Yeah, I think there's been like 10 years or more of this practice and hundreds of reported cases in the literature, and we don't really see late arthritis from piercing the articular cartilage with the guide wire as being a problem. Tom, do you do hand screw insertion or power screw insertion?
I started on power, and I go probably 3/4 of the way down and then fine-tune it to get the feel for the bite, so to speak. So I'll do 3/4 power and then last by hand.
Yeah, I think if I can do it all by hand, first of all, I'm really lucky. So it's really not going to happen. Second of all, I'm really happy because it's just easier. It's another decreased step. But I think what's really important is getting the bevel correct.
Right.
Are there any clues to bevel insertion that you use, Noman?
I think there's laser marking on there, but I'm just moving sometimes too fast and I always forget about it. And I do it on power and then I'm like, okay, stop right here. Let me check. So by that time I've lost the thing. So I don't know. If you have a good tip, let me know.
I'd say be a little more patient, slow down.
I know.
Slow is smooth and smooth is fast.
I know.
But no, the laser line on the screw can be a good indicator, but once you've lost the laser line, you don't have that anymore. Yeah. But it's a great indicator, at least at first. Which screw size do you use, Joe?
My default is to utilize 240 screws. I like the purchase and the stability of the screws. It all depends upon real estate. So if I can at least get the proximal 4.0 millimeter screw in, and the distal one, if I need to mix and match, I'll put a 3.5 distally.
Noman?
Yeah, I start off with the proximal being 4.0 and the distal being 3.5, but I've switched to more 3.5s for both screws to give myself a bailout on using a bigger screw proximally if needed. So that's my thought process.
I think it'd be interesting to look at it in the lab, but I think 2 3.5s are probably very sufficient for this fixation, but I tend to use a 4.0 and a 3.5. Tom?
I go 2 3.5s. And if the patient's a little bit bigger, I'll consider upping that to a 4.0. But my go-to for most patients with a quote-unquote normal size foot is 2 3.5s.
So Tom, you talked about when we first started doing this, we were using compression FT screws, and the compression FT screws has about 4 millimeters of shortening built in, which we don't need anymore. What do you think the advantages of our new screws, which are non-compressive?
Well, it's huge in that what I used to see sometimes with the compressive screws is you can lose a little bit of your correction. So you can shift it back. You think you really like where it is, you have it in a great spot, K-wires in place, and then once the screws engage, they're so good that they compress it and you decrease your correction a little bit. So with these non-compressive type screws, you won't see that.
So you just have like a neutral fixation that ideally you're drilling the full length of the screws, so you're not getting distraction, but you're not getting any compression or any angular deformity that's going to allow you to lose compression.
You know, I was a little concerned when it first came out about increased non-unions, but I personally haven't seen it. And before you're putting the screws in, you do want some connection in the bone. I mean, I think if you had that in outer space and there's a huge gap, I don't think it's going to heal. So you want this to be reasonable. The screw's not going to do what the old screws did, but if it's lined up, touching, you don't need that extra compression and you don't lose that correction that you'd get from the shifter.
So it sort of flies in the face of everything we've always learned about bone healing is, well, stability, of course, these provide great stability, but compression is critical for bone healing, right? But we're not really getting any compression here. What do you think is going on that allows us to get bone healing, Noman, in the absence of compression?
I think in the end, it has to be biology. We've done what the AO guys have always said. We've minimized our soft tissue stripping. We've early mobilized them. We've provided stable fixation. And all those combined factors, and then dedicated instrumentation, done it. But then if you look at anatomically, our vascular supply is maintained. We have the interosseous muscles are right there. The periosteal sleeve is right there. So all those factors that the AO guys and us we have learned, the principles, it's AO compliant.
Yeah, think of a kid who has a displaced distal radius with a big amount of displacement, and you have that sort of triangle of that. You don't see the periosteum, but you know that's going to fill in. I think that's exactly what's going to happen, right? Part of the difficulty in doing this procedure is inserting the guide wires for the screws. One of the things is we're going sort of at a tangent to the lateral cortex, and the thinner guide wires always skive off the lateral cortex before they find their right position. Do you have any tips in avoiding that?
So that was an issue with the previous and other screws, is that the cannula of the screws required a smaller diameter guide pin, and this was very flimsy. So the newer guide pins with the newer screws, because they have a larger cannula, will now allow us to utilize a 1.4 or 1.6 guide pin. So it's a larger cannula of the screw, but also shorter threads. So it's just as strong with adequate pull-out strength as well. So you have the best of both worlds. You have a stable guide pin with appropriate fixation with the screw.
So you have a larger cannula in your screw, right? And that doesn't weaken the screw?
No, because of the shorter threads and the engineering behind the strength of the screw, again, you get the best of both worlds.
But if you change the threads, is the pull-out strength going to be the same, Noman?
If you change the threads, I think the benefit is the minor diameter. By increasing that, and it matches closer to the major diameter. It's what's giving us the best of both worlds, despite a larger inner cannula.
So when we look at these mechanically, they're actually stronger than the previous screws we used. They're stronger than any of the competitor screws, and they have a better pull-out strength.
Absolutely.
So that allows us to really safely and confidently have our patients start bearing weight almost immediately with these, right?
And then the fixation contracts and making sure it's bicortical.
Yeah, I think that's key. I don't think we can emphasize that enough. And we'll probably talk about that again, and everybody will be tired of hearing about it, but it's really, really important.
Really being patient when you're drilling that K-wire in that lateral cortex. If you can just take your time at that step, let the wire do its job and find its path. If you're kind of pushing hard and kind of putting a little too much English on it, I think that's when you can get the skiving.
It's funny because if you think about the strength or the stiffness of the wire, it's going to be exponentially related to the diameter. So really small, it's actually percentage-wise, it's a fairly large increase, and it's going to give you a much stiffer guide wire that's much less likely to skive and make everything a lot easier. So we've got our screws placed, right? We've got this huge shift of the metatarsal. The proximal metatarsal then is going to have this shelf medially that could be problematic. How do you determine what to do about that, Joseph?
That's an intraoperative decision, and you palpate, and if it's not prominent, I tend to leave it alone. Even if it radiographically looks prominent, if I can't palpate a prominence, I will leave it alone. If, however, I palpate and there is a prominence and it's going to be a problem for the patient, that's when you need to address it. I'll do some soft tissue dissection. Initially, I'll use a rongeur to take off a large part of that shelf.
So where does a rongeur go?
From the medial first metatarsal neck initial incision.
So through our osteotomy incision.
Exactly.
And do you elevate the bone medially off of that to give you a little area to put the rongeur in?
Exactly. After that soft tissue dissection, you can elevate up with a freer or rationale, and then grab that portion of the bone, and then soften the edges and the prominences with I like to use a larger burr, whether it's a 3.9 or 4.3 millimeter burr at that point.
Do you have any insight into
Yeah,
what to do with the medial shelf?
What Dr. Park mentioned, you palpate, and I've found it because I'm doing a large shift, 90+% of the time, it invariably is palpable. So what I do is release the soft tissue above it so I can create a pocket that allows my burr to then be placed intramedularly to create almost like a fracture of that segment.
So do you place the burr through the osteotomy incision, distal to proximal? Or do you go another incision proximal to distal or through a screw incision?
Sure. The distal screw tends to be in the right spot to go from proximal to distal. And if there is a big enough shift and the angle on a large IM is there, it's easier to go from distal to proximal. So either whatever is easier is used for me. And as long as I can just get in the angles so not to irritate the distal screw, I use that. And then I just create effectively a fracturoplasty where I'm weakening the bone, and then I smush it back into the canal, and that's what serves as a scaffold graft for the bone to heal on.
So if we're taking off this proximal shelf, do you worry about destabilizing the distal screw, Tom? Because that's right next to where the screw's in place.
Well, I think it's a concern, and it's another reason why you want your screws pretty proximal. And the more proximal you are, the more safely you can remove that shelf. When I first started and put the screws more distal, it would be really a concern, and I'd sometimes just leave it because I didn't want to destabilize that more distal screw. Now, as I place the screws more proximally with the help of the guide, it hasn't been an issue. Noman taught me that trick he just mentioned, which is great. Before then, I was using the 4-3 conical burr and kind of shaving either proximally to distally or distally, whichever way fit better. But I was worried about the nerve, and it would work, but I like his technique better now, where you just almost create a little fracture plane and then impact that as bone graft in that area.
So I used to go through the distal screw incision, but I found that I'd have to put so much tension on that incision to get distal to that screw, to maintain cortex, that I'd tear the skin.
Right.
So I found that just a little controlled incision, very small controlled incision, it's another incision, which, yeah, we want to avoid incisions because it's minimally invasive, but I think a small controlled incision is much better than kind of placing tension on the skin and tearing the skin, because it looks horrible when you do that. How many of you are doing an Aiken with every bunion? Tom, how often are you doing an Aiken?
80 to 100%, almost all the time. I think it does add to the cosmesis. It isn't something that should be totally overlooked or an afterthought. You can get tripped up in the Aiken part, but I'm doing it routinely. I think it can help with the rotation a tiny bit, but definitely cosmetically can help straighten them out. And even some of the older patients who get some impingement, I'll do just an MIS Aiken by themselves and not do anything with the metatarsal, just to get that offloaded the second toe. And so that's a small thing to do. It's another little trick to have in your tool shed, but I do it very commonly.
Noman?
Yeah, I think in the beginning for people that are starting out with this method, I think the Aiken should be nearly on every case, because what you're going to do or have a tendency to do is not shift enough, or you're not going to derotate enough. So for those factors alone, I think by doing the Aiken, you not only cosmetically make it look better, but mechanically realign some of the structures that are going to protect your correction. So I think the Aiken has to be in the conversation in the beginning always. And I think as you dial it in, like I have started to do less of it, but it's still in the high 90 plus percentile where I'm doing an Aiken.
Yeah, so I do an Aiken, I think virtually every case. I think Hans-Georg Trinka, he wrote like the bunion, the Aiken's the last step of every bunionectomy. It not only does it enhance the cosmetic outcome, and we're fooling ourselves if we don't think that part of the outcome is cosmesis is important, but it also significantly enhances the mechanical axis, and it improves the pull or normalizes the pull of the flexors and extensors. So are you doing an Aiken on everybody or almost everybody?
A large majority. I mean, for all the benefits that were mentioned already. Prior to MIS, I was shying away from doing that because technically, for me, it was difficult. And I found that with MIS, it's much easier to utilize that MIS burr for that wedge and to place the screws percutaneously.
So you said it's easier. What size screw do you use?
2.5.
So don't you find that 0.86 millimeter guide wire a little bit difficult?
You know, I think from being used to it, from using it from other procedures, and it's a shorter bone than the first metatarsal, so I don't find it to be, the flimsiness of the guide pin to be as big of an issue.
And how do you orient your osteotomy?
X marks the spot for me, so I think about where the osteotomy will be from distal medial to proximal lateral, and I'll place a screw perpendicular to that from proximal to distal.
Noman, do you use a 2.5 screw?
I do. The 2.5 is a nice compressive screw, and it can really dial it in if you need a little bit of a correction. I have used the beveled screw when I didn't want too much compression. So I think both of those options are available.
I put my K-wire in first, make sure on the AP view that I'm hitting the lateral cortex of the proximal phalanx, and then I know, based on the lateral too, that I'm not too dorsal or too plantar. It's kind of a cylindrical. And then I'll back that up, and then I'll make my cut from distal medial to proximal lateral, careful not to aim it too sharply, to be too close to the joint, and then kind of green stick that lateral cortex and just crack it over, and then pass the guide wire.
So I'll do my osteotomy sort of transverse at really proximal to the metaphyseal-diaphyseal junction, because I think the more proximal you get, the better correction you'll get. But then I'll put in a 2.5 screw. So we've done the Aiken, and now what about medial eminence excision? Do you do that routinely?
Not routinely, very rarely, I would say, but almost the same process as to the medial shelf. I'll palpate, and if it's prominent, I'll do a little bit of soft tissue dissection and shave that down a little bit. I try to minimize and avoid that altogether, just to keep that capsule intact, less dissection, less scar tissue buildup as well.
Are you taking out the medial eminence?
No, almost never, unless when I'm done rotating the head, it ends up dorsal, and it's almost like a cheilectomy
like
type
almost
of
like
spur.
a dorsomedial bone spur kind of thing.
And you
Yeah,
can
that can be
palpate it.
painful. And I've seen patients where I kind of didn't pay attention to that. Patients were dissatisfied with that bump right there because it makes it hard to wear shoes. Tom, how often are you taking out the medial eminence?
Rarely, but occasionally, sometimes you'll see kind of a mix of hallux valgus, hallux rigidus that has that little prominent medial eminence, and I'll go after those. And then I have seen a couple patients, both postoperatively and intraoperatively, once you've rotated it and shifted it, they just have that dorsal medial eminence, and I'll shave that down intraoperatively. The problem with removing it ahead of time is the shifter may sink into the bone a little bit.
So with these big corrections, you've gotten a great correction and you have no prominent bone, but you still have this big bump there from redundant soft tissue. Are you compelled to do anything about that? Do you feel like you should take it out?
I think it's important to tell a patient ahead of time. It may look like you have a little bit of a residual bunion on your first visit or second visit, but that contracts, that remodels, and I haven't had to re-imbricate that or tighten that skin or remove skin ever.
Yeah, this huge bump that's still there because of redundant skin, it goes away invariably, right?
Right.
Do you have similar experience?
Exactly the same, and I've even told others that reached out to me like, hey, would I need to take this off? And I've told them you got to trust it. It will shrink down, and sure enough, they send me pictures afterwards. I couldn't believe, which they were used to excising before, that the skin shrunk down.
Yeah, so even if I was doing an open chevron, I'd take the extra skin off, but I don't feel the need to do that. A lot less pain. a lot less postoperative swelling, and less potential for complication from another big incision. What about, are you doing a lateral release?
A short answer is no. And I feel like the osseous correction is adequate. And you need to be careful about overcorrection. And this can cause a varus. Not to say no across the board. There are a few instances, and but I would say try to stay away from utilizing that.
Yeah, I think you've decreased the tension certainly on the adductor by the shift, and then everything else kind of follows with it. And the incidence of lateral release is really, really low. How would you do a lateral release, Tom, or do you do it at all?
I do it very rarely. I did it early on, I think because I had a suboptimal correction. I hadn't shifted it enough, so I thought, I'll do a lateral release and then bolster this for a while. So it was more of a lateral capsule release with either a beaver or 15 blade. I wouldn't really go down and try to get anything off the sesamoids. I would just kind of on the fluoro go in laterally and then just make a little poke hole and then the lateral capsule. But I think learning from that, I think it's needed very rarely. I think in those cases, what I should have done is backed up more of a shift. These aren't going to get better with time. If you haven't corrected it in the OR setting, it's not going to improve. So you really want to leave the OR confident that you got this well corrected.
Yeah, I think like a soft tissue bunion correction is a myth. And that's what, 130 different types of bunion procedures, a lot of which involved poorly considered osteotomies. And then it was all made up for intraoperatively by doing soft tissue imbrications or soft tissue releases, and they'd invariably fail. But I think by correcting the mechanical axis with a big bony shift, we've been able to achieve a very durable, reliable bunion correction. Thank you for joining us on this discussion of the beveled FT screws and general fixation methods. Please watch some of our other episodes to learn more about the Arthrex bunionectomy and our experience with MIS bunion correction. Thank you.